This conference will now be recorded.
Hello everyone, is my voice audible? And the screen visible just right down in the chat box? Hello.
Yeah, you're audible, Rashmi.
Hi Gitika. So we'll start off with the introductory session for today. So today we are having the three topics. One is the introduction to part 2 MRCOG. Then Dr. Gitika will be taking the GTG, cervical cerclage, the key points, and introduction to EBCOG by Dr. Jatinder Kaur. So to begin with part 2 MRCOG, here we all know that after clearing part 1, the difficult part is the part 2 because it consists of the SPAs and the EMQs. Now, how to make this thing easy? We all know that success doesn't come to you. You have to go to it. So how can we improvise upon this? How to go stepwise? How to channelize from solving SPAs to solving the EMQs also? At the same time building the concept so strong that even any point of guideline, any question that has been asked, you will be able to solve it. Not only the recalls, the concept have to be clear, and the recalls especially which are derived from these guidelines and all, so they have that the base. So once you know your guidelines thoroughly, you will be able to solve all the SPAs and the EMQs. So we'll be telling you how to go ahead with that and how to identify all the key points in the guidelines too. The format of Part 2 MRCOG. Nowadays, it is online exam. So the Pearson VUE centers, they hold this exam. We have to reach the centers and then using their computers, their systems, we are supposed to perform that exam. It consists of 2 papers, 3 hours each with break in between. And it consists of the single best answers and the extended matching questions. These extended matching questions, these carry more marks compared to the SPAs. It is seen that the distribution is 50-50, but the percentage wise, if you see, it shows that the extended matching questions are worth 60% of the total marks. That is why this is very important. We are all used to solving the single best answers in our part 1. What is different is how to solve the extended matching question, how to rule out all the options. Amongst the 15-20 options that have been given, we'll be teaching you how to exclude and arrive at 3-4 different options, and then how to choose the best one among those 3 or 4 options. So this is from the RCOG website. It clearly tells that it's a computer-based test. SPAs are worth 40% and the EMQs are worth 60%. Part 1 paper is of 3 hours duration, that is 180 minutes. It will consist of equal number of questions. See the difference. The question numbers are equal, but the percentage that they carry of the total marks is different. The time management, we have to manage it accordingly. It is nothing like this much is for SPA, this much is for EMQ. But it is expected that at least these 50 single best answers we are supposed to finish in 70 minutes. And trust me, this can be over earlier than 70 minutes. And the remaining questions will be solved in 110 minutes. That is the EMQs. There will be a break of about 60 minutes approximately. And after that will be the second paper, the same day. It will also consist of 3 hours, 180 minutes, and again 50 SPAs and 50 EMQ. There is no clear demarcation between the papers like pure obstetrics and pure gynecology. Sometimes the questions could overlap also. Now, what about the expression of interest? So earlier it was like for the part 2, we need to have 4 years of experience, but now it is changed. It clearly tells that before attempting part 3, we have to produce the 4 years experience. So July 20, the 2022 part 2 exam, here the expression of interest deadline is 9th of March 2022. Remember this because all of you who are planning to sit in July exam, who have cleared their part 1, you are supposed to show the expression of interest. So what you're supposed to do, go to the website, log in into your account, open this part 2 exam. In that, go to the expression of interest. It comes down, you need to scroll down here and try to enter all your details over here and then submit option. Once you have shown the expression of interest, then you will be getting the booking link. So after that, the token is sent to you, to your registered mail ID. You need to open that and then you need to book your exam. Just watch out for these dates. We all know the expression of interest. It is already opened by 23rd of September last year itself. It's going to close by 9th March. So be sure that you're going to book this first. The booking tokens will be sent to the candidates on 28th of March. Remember, this is only token. Receipt of a token doesn't mean that you have booked your exam. This is only the token which has been sent. This token should be opened during 30th of March. So the application window opens on 30th of March. So please book your exam on 30th of March itself. Although it mentions that it is going to close by 13th April, all the seats may not be available as and when the day passes. So you are supposed to book your exam on 30th of March 2022 itself. After the candidate has booked the exam, the candidates are contacted to book into the Pearson VUE centers. So the center contacts them and then the confirmation is sent to them. So by 27th of April, the candidates will be contacted to book into the Pearson VUE centers. So different dates. Please watch out for all these dates. Remember, all the people who are planning to book your exam, make sure you are submitting the expression of interest by 9th of March. What are the study materials and how to go ahead with the preparation? There are lots and lots of books and materials and guidelines which are available. So how to organize them and how to go ahead with them one by one. The difference here is we all do our hard work. But what's the difference between the hard work and smart work here? We have to give priority for both quantity and quality at the same time. We have to be flexible and have some effective ways of delegation of our own study pattern. We should make sure that whatever time restraints we have, we are utilizing that best. We have to show efficient and effective study. How we are going to do that? We all have work commitments, we all have family, we all have different commitments. So we are supposed to organize our time. Tell yourself from today onwards, we have to set this particular time. People have done their part 2 and part 3 during their working hours, not taking leave, managing the household things, managing the work schedule properly, managing different jobs efficiently. So it's not a difficult task, but yes, time management is very important. How you organize yourself, how you're going to study yourself, like how it has to be scheduled properly. All these things are really important. So we have to divide our entire day schedule depending upon our free time, which is available. And the available free time has to be made best use of. That is how you're going to do the smart work here. We do have the green top guidelines. This is the essential thing for RCOG exams. So the green top guidelines are a must. Nowadays, more and more the guidelines have been released and definitely they are going to be asked in July exam. So we'll be covering all the guidelines, all the recent ones too, the NICE guidelines, important TOG articles, the FSRH, the BASH and the FIGO articles, then the cervical screening programs, the consent advices, scientific impact papers, and the ESHRE guidelines. Apart from this, a very important source is the strategy. Strategy has a lot of materials on the clinical governance, teaching, and other important topics there. Plus, the strategy has its own set of questions. These are really important because as and when the things are being updated, the strategy answers may vary sometimes. We always have to keep them cross-checked with the green top guidelines, but at the same time, they have good quality questions. Most of the times it is the clear copy paste of the strategy questions too. And strategy have the TOG SBAs also. So those are also important. And they have some study materials as part 1 exam questions, part 2 exam questions, and the part 3 circuits. So we do recommend that you can subscribe to the strategy and then take a membership and then you go through those questions also. A really good source of questions have been provided in the strategy. What about the books now? There are lots of books which are available and we'll be covering all of them. So for the single best answers, we do have the Andrew Sizers and other books. So recently, the Andrew Sizer, it has been released a new one. The Get Through have been updated. Then we do have the Bryants. We have Amanda Jones, which is the RCOG book. So this is a must. So all these books, we'll be covering them one by one. We have already started that in the course groups, and the schedule has been put up for them. Then we have the extended matching questions. So these are really important solving books. However, few books like the Kalaivani and other things, they are a bit older one. Then a lot of things in the like Andrew and Andrea Pilkington, these have to be updated. But the quality of questions are good. We need to compare that and then go ahead with the GTG based things. So in this, we can also see that the single best answers provided by the Srilata Datta and the Tahir Mahmood, these are important. The Get Through have released the new questions on the MQs, those are important. Whatever questions we are reading, we have to cross check with the guidelines. That is important because sometimes they would have picked up the answer from the older guidelines, and that will be telling how to go ahead with the newer concepts. So a lot of books have been released for the extended matching questions too. The next step planning, what we are doing since like almost February, we have started off with the new course. So they have been following the schedule. The new course, we are putting up day-wise basis how it is done. So for example, like 5th of March, I have put up all the asthma talk, the talk of the October articles and the Get Through SPAs. So every day they are targeting only small topics there. So the entire week schedule, whatever they are going to listen in the live session, they'll be reading it prior, getting some knowledge regarding that. And once in the live session, they are listening to that, it is going to be strengthened again. So every day we are putting up schedule for them, and we are encouraging to solve the recalls questions too. So in this way, you will be covering the articles which are required, the books which are required, the talk articles required, and the recalls, and listening to the live sessions, and the recordings will also be available. In this way, stepwise, we have to target the exam. Every day it has to be arranged, and then weekly sessions, and then in the June we are going to do the revision. That is going to be the targeted revision, and that is very important. Most of this we are targeting the recalls here. So it's going to be the recall based revision, the topics with the explanations. After this is going to be a quick revision prior to the exam, which will be 10-day based. This is a marathon revision what we target. So this is the 3-step revision which you have to do before you take the July exam. So the wait is over. We are offering a course. So this has already been started. The recordings will be, however, available. All the guidelines, important talk articles and other questions will be covered. We are building up the website where we are going to add all the question pools and the free mock test. We are solving the questions in the Telegram group. You may be already aware about all the questions that have been put up in the free group. So a lot of new questions we are framing actually from the Green Top guideline itself, so that you are aware about what exactly we need to concentrate upon. And when we take the live sessions, we'll be emphasizing on all the recalls that have been asked. We are highlighting them as an SPA, MQ or a recall. And these session recordings will be again uploaded for listening to you people again and again, so that the revision becomes easier. Plus, we'll be giving the access to the course library there. So currently we had closed the offer, but only for 24 hours. On request of the students, we'll be keeping this offer again. So from tonight till tomorrow night, 8 o'clock, 8 p.m. Sunday night. So we are closing that offer. So 29,500 INR will be there. The interested candidates, please do contact me. Then I'll be providing you the link for the payment. Okay. So let's start the journey. And now I'll be handing over to Dr. Geetika for the key recommendations on the GTOP guideline, which is recently released on cervical cerclage. Thank you so much. Dr. Geetika, are you there?
Yes, Rashmi. So is my screen visible?
Yes, dear.
Okay, fine. Hello, a very warm welcome to you all to the free session by Raise Academy. So I'll be covering one of the recent guidelines which has been put by RCOG, that is Green Top guideline number 75. So this includes all the important points regarding cervical cerclage. So let's start with this. So let's go through the key recommendations first. So the guideline says that women with singleton pregnancy and 3 or more previous preterm birth should be offered a history-indicated cervical cerclage. So if the female is having 3 or more previous preterm births, she is a candidate of history-indicated cervical cerclage. Women with a singleton pregnancy, so remember this, they are talking about singleton pregnancies, okay? This word is very important. And history of spontaneous second trimester losses or preterm birth who have not undergone history indicated cerclage may be offered serial sonographic surveillance. So remember this word, serial sonographic surveillance, as those who experience cervical shortening may benefit from ultrasound indicated cerclage, while those whose cervix remains long, that is greater than 25 have a low risk of second trimester loss or preterm. So on serial sonographic surveillance, you are going to look at the cervical length, and if the cervical length becomes 25 millimeter or less than that, then you can go for ultrasound indicated cerclage. This is for females who have not undergone history indicated cerclage. For women with a singleton pregnancy and no other risk factors for preterm birth, insertion of cervical cerclage is not recommended in women who have an incidentally identified short cervix. So if incidentally you find that the cervix is less than 25 millimeter on ultrasound, this is not an indication if the female has no other risk factors for preterm birth. In women with previous unsuccessful transvaginal cerclage, insertion of transabdominal cerclage may be discussed and considered. In women with singleton pregnancy, insertion of emergency cerclage may delay birth by an average of 34 days. This is very important number, and this can come as a single best answer compared with expectant management, bed rest alone, or in suitable cases. This may also be associated with twofold reduction in the chances of birth beyond 34 weeks of gestation. The choice of transvaginal cerclage technique should be at the discretion of the surgeon, but the cerclage should be placed as high as practically possible. This is important. Let's go through some definitions which are given in the guideline. What is history indicated cerclage? Insertion of a cerclage as a result of factors in a woman's obstetric or gynae history, which increases the risk of spontaneous second trimester loss or preterm births. A history indicated cerclage is performed as a prophylactic measure in asymptomatic women, and this is usually done between 11 to 14 weeks of gestation. Ultrasound indicated cerclage, insertion of cerclage as a therapeutic measures. So this was prophylactic and this is therapeutic in cases of cervical length shortening seen on transvaginal sonography. Ultrasound indicated cerclage is performed on asymptomatic women who do not have exposed fetal membranes in the vagina. Sonographic assessment of the cervix is usually performed between 14 to 24 weeks of gestation by transvaginal scan and with an empty maternal bladder. So remember the gestation at which we are doing sonographic assessment of the cervix, it is between 14 to 24 weeks by transvaginal scan and the bladder should be empty. What is emergency cerclage? Emergency cerclage is also known as physical examination indicated cerclage. Insertion of cerclage as a salvage measure in the case of premature cervical dilatation with exposed fetal membranes in the vagina. So it is performed in emergency when the cervix is dilating and the fetal membranes are exposed. This may be discovered by ultrasound examination of the cervix or as a result of per speculum or physical examination performed for certain symptoms which the female has, like vaginal discharge, bleeding, or sensation of pressure. So this emergency cerclage should be considered up till 27 plus 6 weeks of gestation. Again, this number is important. 27 plus 6 weeks. Till 27 plus 6 weeks, you can consider doing emergency cerclage. Transvaginal cerclage, which we commonly call it as McDonald stitch. So a transvaginal piercing suture is placed at cervical isthmic junction without bladder mobilization. So McDonald stitch, you are not mobilizing the bladder. High transvaginal cerclage requires bladder mobilization, and we call this stitch as Shirodka stitch. A transvaginal piercing suture placed following bladder mobilization to allow insertion above the level of the cardinal ligaments. Transabdominal cerclage is performed, suture is placed, performed via laparotomy or laparoscopically. It is the suture is placed at cervico-isthmic junction. Occlusion cerclage. Occlusion of the external os by placement of continuous non-absorbable suture. The theory behind this is that the occlusion cerclage results in retention of the mucus plug, and this prevents the labor from progressing further. Now, let's go through each one of them one by one. So history indicated cerclage. Women with singleton pregnancy and 3 or more previous preterm births should be offered history indicated cervical cerclage. History indicated cerclage should not routinely be offered to women with less than 3 previous preterm births or second trimester losses without additional risk factors. It is unknown if the specific characteristics of previous adverse events are helpful in the decision to place a history indicated cerclage, like painless dilatation, rupture of membrane, or prior cervical surgery. Ultrasound indicated cerclage. So when should ultrasound indicated cerclage be offered? In a woman with singleton pregnancy and no other risk factors for preterm birth, insertion of cervical cerclage is not recommended in women who have a short cervix incidentally identified. This I have told earlier also. So if the cervix is incidentally found to be short, less than 25 millimeter, then this is not an indication that you should go for ultrasound indicated cerclage if the female doesn't have any other risk factors. Women with singleton pregnancy and history of spontaneous second trimester loss or preterm. So women with history of 1 or more spontaneous second trimester losses or preterm birth who are undergoing ultrasound surveillance of cervical length should be offered cerclage if the cervix is 25 millimeter or less at gestation less than 24 weeks. So we all know that we are doing surveillance between 14 to 24 weeks. So whenever during the surveillance we found there is a history, the female is carrying singleton pregnancy and there is a history of previous second trimester loss of preterm birth and the cervix comes out to be less than 25 millimeter, that is an indication where you have to put an ultrasound indicated cerclage. Ultrasound indicated cerclage is not recommended for funneling of the cervix. This is important. Just the funneling of the cervix in the absence of cervical shortening to 25 mm or less is not an indication for cervical ultrasound indicated cerclage. So funneling of the cervix is not an indication. It is the length of the cervix you have to monitor. And if the length becomes 25 mm or less, then definitely you have to go for ultrasound indicated cerclage if there is a history of previous spontaneous second trimester loss or preterm birth. But mere finding of cervical length less than 25 mm or less than 25 mm without any history is not an indication again. Who should be offered serial sonographic surveillance with a view to ultrasound indicated cerclage? Women with history of spontaneous second trimester loss or preterm birth who have not undergone history indicated cerclage may be offered serial sonographic surveillance, as those who experience cervical shortening may benefit from ultrasound indicated cerclage. Ultrasound surveillance of cervical length is advocated in women at high and intermediate risk in element 5 of Saving Babies' Lives Care Bundle. the timing of which is dependent on the women's history. The females who are considered at higher risk include those with previous preterm birth or second trimester loss between 16 to 24 weeks, with previous preterm pre-labor rupture of membrane at less than 34 weeks, previous use of sarclage, known uterine variant, intrauterine adhesions, history of trachelectomy. So these women are recommended to be reviewed by the preterm prevention specialist by 12 weeks where possible, or with dating scan, whichever is sooner. And they should be offered surveillance with transvaginal scan for the cervical length as a secondary screening test every 2 to 4 weeks between 16 to 24 weeks. So between 16 to 24 weeks, every 2 to 4 weekly, these females should be screened for their cervical length. Women who are at intermediate risk, these include women who have history of previous full dilatations, cesarean section with significant cervical excisional surgery. That is, they have undergone Let's procedure where the excision depth was greater than 1 centimeter, or they have undergone a repeat procedure or a cone biopsy. These are the females who are at intermediate risk of preterm delivery. These females should be offered a single, this is not serial surveillance for them, a single transvaginal cervical scan should be offered to them between 18 to 22 weeks. And these timings are based on the consensus of experts from the UK preterm clinical network. So this is important, and this has been given by element 5 of Saving Babies Life Care Bundle. Can cervical cerclage be recommended in any other groups of women considered at increased risk of preterm birth? So regarding multiple pregnancies, the insertion of history or ultrasound indicated cerclage in women with multiple pregnancy is not recommended. There is a randomized trial which was going on, Stop It 2. It was a randomized trial of rabin-pesri to prevent preterm birth and twin pregnancy with short cervix. So data collection is now complete, but the results are still being analyzed. For the females with cervical surgery, trauma, or uterine abnormalities, the role of history or ultrasound indicated cerclage is uncertain. According to GTG guideline, the role of the cerclage, history or ultrasound indicated cerclage in females who had cervical surgery, trauma, or uterine abnormality, there the role of history or ultrasound indicated cerclage is uncertain, who display no additional risk factors, such as the women with Mullerian anomalies, previous cervical surgeries like cone biopsy, LITS, destructive procedure, such as laser ablation, diathermy, or multiple DNCs. So there, the GTG says that there is no role as such for history or ultrasound indicated cerclage if these females do not have additional risk factors. Women with raised BMI, the guideline says that cerclage is effective in women with raised BMI. So if the BMI is more than 25, then it is not that like a cerclage won't be effective. It is effective. Transabdominal cerclage in women with previous unsuccessful transvaginal cerclage, insertion of transabdominal cerclage may be discussed and considered. This can be performed preconceptionally before the female gets pregnant or in the early pregnancy. Definitely preconceptional insertion should be considered where possible because of the reduced anesthesia risk and technical advantage of operating on a uterus on a non-pregnant uterus. So definitely we should prefer going for preconceptional cervical cerclage if we are going for transabdominal cerclage. Furthermore, there is evidence that preconceptional transabdominal cerclage has no detrimental effect. So there is no evidence that it has any detrimental effect on future fertility or care and treatment of early miscarriage. Transabdominal cerclage is usually inserted following an unsuccessful vaginal encerclage or extensive cervical surgery. It can be done laparoscopically or through laparotomy. Open abdominal cerclage can be done. But laparoscopy, we all know it has its own added advantages and there are fewer complications. So this should be considered the first line if the expertise is there. How should women who experience delayed miscarriage or fetal death be cared? So the decision on the care and treatment in cases of delayed miscarriage. So with transabdominal cerclage, if the female has delayed miscarriage or fetal death, so in that case, the decisions on the care and treatment can be difficult, and the women decisions making should be aided by the senior obstetrician. Complete evacuation through the stitch by suction curettage or by dilatation and evacuation up till 18 weeks of gestation may be performed. Alternatively, the suture may be cut via a posterior colpotomy. So you can do posterior colpotomy and you can cut the suture and then you can go further. Otherwise, definitely through the stitch also till 18 weeks, you can perform suction and curettage or dilatation and evacuation. Failing this, if this fails, then definitely hysterectomy may be required or cesarean section may be required. But the woman's decision should be aided by a senior obstetrician. Talking about emergency cerclage now. So the decision to place an emergency suture should be individualized, taking the parent's view carefully into account. Insertion of emergency cerclage may delay the birth by approximately 34 days in suitable cases. So the confidence interval is between 18 to 50 days. Compared with expectant management and bed rest alone. So definitely emergency cerclage, going for emergency cerclage as compared to expectant management is beneficial as it is delaying the birth by around 34 days. It may also be associated with twofold reduction in the chance of birth before 34 weeks of gestation. However, there is only limited data to support an associated improvement in neonatal mortality and morbidity. So emergency cerclage doesn't have much benefits if we talk about neonatal mortality and morbidity, but definitely the birth gets prolonged by around 34 days. And there is twofold reduction in the chances of birth before 34 weeks. Advanced dilatation of the cervix, that is more than 4 centimeters, or membrane prolapse beyond external os, appears to be associated with high chance of cervical cerclage failure. So if the cervix is more than 4 centimeters, we call it as advanced preterm labor. Or if the membranes, they have prolapsed beyond the external os, then the chances of failure of emergency cerclage, they are more. There are certain contraindications to cerclage. These are very important. Active preterm labor, that is more than 4 centimeters dilated, clinical evidence of chorioamnionitis, continued vaginal bleeding, preterm prom, evidence of fetal compromise, lethal fetal defect, and fetal death. So these are the contraindications to cerclage insertion. What information are you going to give to the female before cerclage insertion? So before history or ultrasound indicated cerclage, insertion, women should be given some verbal and written information about the potential complications. Before any type of cerclage, you have to discuss with the female that there is a small risk of intraoperative bladder damage, cervical trauma, membrane rupture, bleeding during insertion of cervical cerclage. Cervical cerclage may be associated with the risk of cervical laceration or trauma if there is a spontaneous labor with suture in situ. So if the suture is there and the patient goes into labor, then there are risks of cervical lacerations and trauma. High vaginal cerclage insertion with bladder mobilization usually requires anesthesia, which has its own complications and risks. For women who are undergoing non-emergency cerclage, that is history-indicated cerclage, vaginal cerclage insertion, in those cases, they are not associated with the risk of preterm prom or chorioamnionitis or induction of labor or cesarean section. The insertion of cervical suture is not associated with increased risk of preterm birth or second trimester loss. Cervical cerclage may be associated with a risk of laceration, cervical laceration and trauma if there is spontaneous labor with suture in place. What is the preoperative management you have to give before cerclage? What investigation should be performed for cerclage? So women should be offered a first trimester ultrasound scan and screening for aneuploidy. So combined tests should be offered to her before insertion of history indicated suture to ensure both viability, singleton pregnancy, and absence of any lethal or major fetal anomaly. So this aneuploidy screening and first trimester ultrasound has to be done before you apply any history indicated sarclage. Before history indicated or emergency sarclage, it is preferable to ensure an anomaly scan has been done. So before ultrasound indicated, before you are going for ultrasound or emergency sarclage, make sure that the anomaly scan has been done. Maternal WBC count and C-reactive protein to detect chorioamnionitis before insertion of emergency sarclage can be used to aid management. So yes, you can do total count C-reactive CRP for her, but the decision to perform this test should be based on the overall clinical picture. In the absence of clinical signs of chorioamnionitis, the decision for emergency sarclage need not be delayed. If she is having no signs of chorioamnionitis, no clinical signs, and the sarclage has to be performed, then you need not delay your procedure just based that you have not done the maternal WBC count or CRP. But so that has to be weighed whether you have to perform or not to perform. But definitely the guideline says that it can be used to aid the management. Should amniocentesis to detect infection be performed before rescue, that is emergency or ultrasound indicated sarclage? There is insufficient evidence to recommend routine amniocentesis, okay, before rescue or ultrasound indicated sarclage, as there is no clear data demonstrating improved outcome. In selected cases, so just note this line, in selected cases where there is suspicion that there is intra-amniotic infection, amniocentesis may be performed to aid the decision about emergency sarclage, as presence of infection is a contraindication and it is associated with poor prognosis. So if you have a clinical suspicion that there can be intra-amniotic infection, chorioamnionitis, then definitely you can just do amniocentesis to look for the culture growth, and you can just delay your emergency sarclage. Amniocentesis before emergency sarclage does not appear to increase the risk of preterm birth before 28 weeks of gestation, but there is likely to be some risk from the procedure. Is amnio reduction before emergency sarclage recommended? So what about amnio reduction? There is absence of data to either refute or support the use of amnio reduction before insertion of emergency sarclage, and this should therefore not be carried out. Do not carry out amnio reduction. Should a latency period be observed between presentation and insertion of emergency or ultrasound indicated sarclage? So each case should be managed on individual basis. The interval between presentation and suture insertion varies between the studies. Any delay must balance the risk of inserting a suture in the cervix that is inevitably going to continue dilating against the increased risk of ascending infection. So you have to individualize the case, whether you have to give a latency period between the presentation of the patient and insertion of any emergency or ultrasound indicated sarclage. Should routine genital tract screening for infections be carried out? So the guideline says routine genital tract screening should not be undertaken before sarclage insertion. But if we already have a positive culture from a genital swab, then antimicrobial therapy should be decided on individual basis after discussion with the microbiology team. Talking about the operative issues now. Should perioperative tocolysis be used for insertion of sarclage? There is no evidence to support the use of routine perioperative tocolysis in women undergoing insertion of sarclage. As we are giving in our practice, we are giving tocolysis, but the guideline says there is no evidence to support the use of routine perioperative tocolysis. And this should be considered again on individual basis. Talking about perioperative antibiotic. So again, the decision for antibiotic prophylaxis at the time of sarclage placement should be at the discretion of the operating team. Again, the operating team can decide whether they have to give antibiotics or not. The choice of anesthesia should again be made by the operating team in conjunction with after listening with the women. So they can have a discussion with the women and they can decide what choice of anesthesia she wants to have. Yes, cervical cerclage, transvaginal cerclage, elective transvaginal cerclage can safely be performed as a day case procedure. Which technique and material should be used? So the choice of suture material again should be at the discretion of the surgeon, and a non-absorbable suture we are normally using, that is silk we are normally using. The choice of transvaginal cerclage technique should again be at the discretion of the surgeon, but the cerclage should be placed as high as practically possible. There is no difference between using 2 purse string sutures and 1 single suture, and this again should be at the discretion of the surgeon. The insertion of cervical occlusion suture in addition to the primary cerclage is not routinely recommended. So some operating surgeons, they just apply a occlusion suture to close the external os after they apply primary cerclage. So the guidance says that there is no role to apply any cervical occlusion suture after the primary cerclage. The role of adjuvant any treatment options, if they are there or not. So the bed rest definitely should not be routinely recommended, but then again it should be individualized, taking into account the clinical circumstances and potential adverse effects that bed rest could have on the women and their families, in addition to the increased cost to the NHS. Abstinence from sexual intercourse following cerclage is not routinely recommended. So is there a role of post-cerclage serial sonographic surveillance of cervical length? So once you have applied a stitch, after that, should the female undergo sonographic surveillance of the cervical length? So the guideline says, while routine serial sonographic measurement of cervix is not recommended, it may be useful in individual cases following ultrasound-indicated cerclage to offer timely administration of steroid or IUT, in utero transfer. In the presence of history indicated cerclage, additional ultrasound indicated cerclage is not routinely recommended as compared with expectant management. So you're not going to offer her ultrasound surveillance. The decision to place an emergency cerclage following an elective or ultrasound indicated cerclage should be made on individual basis, taking into account the clinical circumstances. So whether you have already put one cerclage, history or ultrasound indicated, and now the patient goes into labor, whether you have to put an emergency cerclage, that will be individualized, and it will depend upon the discussion with the female and her clinical circumstances at that point of time. Is fetal fibronectin useful following insertion of cervical cerclage? So routine fetal fibronectin testing is not recommended post cerclage. However, because this test has a high negative predictive value, therefore it will tell that the chances of delivery, if it is negative, it will make you sure that the patient is not going into labor for the next 2 weeks. So however, the high negative predictive value of fetal fibronectin testing for subsequent birth at less than 30 weeks of gestation in asymptomatic high-risk women with cerclage in place may provide reassurance to the women and the clinician in individual cases. Should women receive supplement progesterone following cerclage? So routine use of progesterone supplementation following cerclage is not recommended. Current NICE guideline do not advise progesterone administration following cervical cerclage. Should women be offered an Arabin pessary or progesterone instead of cerclage? There is no evidence that either progesterone or Arabin pessary alone are more effective or less effective than cervical cerclage. When should the cerclage be removed? So the transvaginal cervical cerclage should be removed before labor. So usually it is removed between 36+1 to 37 weeks of gestation, unless the birth is by pre-labor cesarean section, in which case suture removal could be delayed till that time. In women presenting in established preterm labor, the cerclage should be removed to minimize potential trauma to the cervix. A high cervical cerclage, which has been placed after bladder mobilization, usually requires an anesthesia for removal. All the women with transabdominal cerclage require birth by cesarean section. So if you have put a transabdominal cerclage, then definitely the mode of delivery will be by cesarean section, and the suture, the abdominal suture, may be left in place following the birth. So the suture can be then can be left in place. No need to cut it. You are going to deliver the baby by cesarean section, and the suture will remain in situ. Should the cerclage be removed following preterm prom? So in females with preterm prom between 24 to 34 weeks of gestation, and without evidence of infection or preterm birth, delayed removal of the cerclage for 48 hours can be considered to facilitate in utero transfer. Delayed suture removal until labor ensures or birth is indicated is associated with high risk of maternal and fetal sepsis, and it's not recommended. So maximum till 48 hours till you have to give, you are considering IUT, intrauterine transfer. Only till that time you can delay the suture, otherwise it should be removed, and you can't delay removal of the suture till the labor starts because there is high risk of sepsis. Given the risk of neonatal and maternal sepsis and minimal benefit of 48 hours of latency in pregnancies with preterm prom before 23 weeks and after 34 weeks of gestation, delayed suture removal is unlikely to be advantageous in this situation. So it is only between 24 to 34 weeks of gestation that we are giving a latent period of 48 hours. Before 23 weeks, after 34 weeks, since there is no advantage of this latency period, so this period delayed removal of the suture beyond 48 hours is not indicated. Okay, so this was regarding the key points from the guideline. I hope it was helpful to you all. So I will hand over the session to Rashmi. Rashmi, are you there?
Yes, thank you so much, dear. Wonderful session. I think everyone are benefited with this new guideline and all the key points you have highlighted. Thank you so much, Geetika.
Thank you, dear.
So thank you. So we have Dr. Jeet here. So she'll be dealing with the orientation to EBCOG. And welcome to Raise Academy. So I hand over to you, Jeet. You can take over.
Hi, Rashmi. Thank you. So I have to share my screen, right?
Yes, dear. You can share your screen.
Okay.
Yeah, it's visible.
Yeah. Okay. Hello, all. So are we all appearing for, planning for EBCOG? Hello.
Yeah, you all can write down in the chat box.
Okay. So all right, I'll see in the chat box. So meanwhile, now today I will be briefly giving you idea about what EBCOG is, because there are a lot of confusion going on in all the many of the candidates, that what benefit it will give, and what different preparation you have to do. So that is why I'm here with few slides to tell you, to give you a overall idea, so that there will be clear in your mind that how to go about it. So first we'll start from now. So I'll be covering the introduction first, that what it is. EBCOG is European Board College Obs and Gynae. This college, it offers a fellowship exam. Yeah, so that is in two parts, part 1 and part 2. So part 1 is your this knowledge base, that is your MCQs like single best answers and EMQs. Yes, and that is going to be online this time. Last time also both part 1 and part 2 were online because of the COVID situation, and now as well because of this thing COVID only, they are conducting part 1 online, but there is no information of part 2. So the dates they have given for the EBCOG 1 exam is 14th May 2022. So that's, I think, hardly 2 months from now. And deadline for application is 14th April. And this will be EBCOG part 1 to be held remotely on 14th May, and it will be one-day event. Last time it was in 2 divided days, but they merged it into 1 day only, obs and gynae. So it is a long exam, lengthy exam, and there are 2 divisions, obstetrics and gynae, and all have their EMQs and SBAs. Yeah, there were no MCQs last time, and I sent a mail to the this examination department, the secretary there. He replied that there will be no MCQs this time as well, but we will again, because there is no information on the website, so we'll see the people who will be booking. So what they get the information, that will be the authentic one, most authentic one, I suppose. That whatever they will send you mail once you book the exam, then they send a mail, and in that there are question and answer, sample questions and answer. In that they give you SBAs, EMQs, then it will be only 2 of them. And if they give MCQs as well, though they have said it clearly that we have removed the MCQ part, so it is very rare that MCQs will be there in this exam. So, and site is opened. You can book the exam anytime till 14th April. So the fees there is 625 euros. Because we are non-European, so we have to pay 100 euros extra. Including 100 euros, it is 625. There is a, when you go to the website, then there is you have to make an ORTREC account. So that's an online account. It is very simple procedure. Just go there, make your account, and they will first, ask you for certain documents, your basic degree, and have you worked in gynae or associated with the gynae program for 2-3 years. And apart from that, then they will be, after your documents check, you have to fill 100 euros for your documents check. If your documents have been verified, they ask for one recommendation letter as well, so that wherever you are working, you can, anyone can write it down, your senior, your superiors, they can give it, and then they will be giving you the good to go sign, and then you can fill the whole fee, pay the whole fee, and your seat will be reserved. Then they'll give you the confirmation. Yeah, I'm coming on to that, like which countries accept this. There are 16 European countries, including, there are Malta, Germany as well. So they are like, there is a long list on their website. But let me tell you, I don't want to, keep you a false hope, give you a false hope or something else. This exam is for your own academic excellence. Even if, there are 16 countries, they accept this, but they have clearly written that we will not be, you have to follow the protocol, like of the medical council. Yes. And in this, like, if you go to, suppose if we go to Germany, we have EBCOG degree. Yeah, that will be very helpful in that those 16 countries. They will accept that, and they'll be welcoming you. But if you are going to register in their medical council, yes, then there are certain exams also which you may have to give. But in certain countries, there are no exam, and on the basis of EBCOG, they accept you. Which countries do that and which country doesn't do that, that we don't know. We don't have any idea, because this is, it is not on the website, and none of us, I hope, we have not worked there, and we have not tried yet, because last year only we have cleared the exam in December. So, and but there are certain benefits of this exam that I'm going to discuss here. That this is, when we cleared the exam, they have sent this these points to us as a fellow. Your name will be there on the EBCOG web page. So that, for me, that's a big thing, you know. Like, it is a prestigious degree, and you'll receive a certificate, and there will be EJOG subscription for you, annual subscription for European General, and then you some discounts and all if you attend the congress and courses there, you know, gynae courses. So and you can write the questions for exam. That is also very lucrative for me, that if, you know, we can write the questions for EBCOG exams. And other than that, other activities they keep on sending. Like, just now they have sent me a mail that you're eligible for this a fellowship they are conducting, you know. Very few seats are there in the Europe. They are reproductive medicine fellowships in which they, you know, teach you everything till oocyte retrieval, and the fellowship is for 1 or 2 years, but they offer only to the fellows who are European fellows. So I mean, if anybody can do that, apply for that, they are very welcome, and they will be given preference. So these opportunities you get. And apart from that, if you are going to work in UK or in Ireland, then you must have a MRCOG degree and MRCPI, whatever their requirements are. EBCOG degree, there also it's a, you know, feather in your academic cap. Yeah, so it doesn't as such give you any license to practice anywhere, that you can go directly and practice. There are some countries which offer that, but I'm not clear about the names, and no one is clear because it's not mentioned there. And so coming on to the point that why EBCOG, and why EBCOG, I've told you that it is your choice. You want to attach a big degree, it is European Fellow of Obs and Gynae when you clear both the parts. Yes, part 2 is OSCE exam, that we can discuss later. And what's different in part 1? Basically, it says, the European board site says that we do not recommend any specific textbook. Okay, no MCQ book, no textbook. And you can follow any currently evidence-based international guidelines. Yes, so in this, what are the current evidence-based? These are the GTGs, these are the NICE guidelines, and there are some ASHRAE guidelines, which are very, very important. So those guidelines are the things which they like we need to know. And apart from that, they says that international recommended textbooks also you can consult. So what we read was Catherine Nelson PSA, which we read for part 3 as well. So from that we took references, but now they have their own set of, you know, this packed curriculum. So we have to prepare whatever we are preparing. We have to prepare according to the packed curriculum. If you are going through single topic, suppose if we are preparing for part 1, yeah, EBCOG part 1. So we are going through any guideline. We have to just go through the similar, like you have to identify the problem. So for this means that history taking, yeah, what points in the history you will take from the patient, and diagnosis, to diagnose the further performance. Without performance of a specific skills, their specific skills are ultrasound. They are very fond of ultrasounds. So they give questions in part 1 as well and in part 2 as well about the ultrasound findings, and they'll give pictures and they want you to comment on that. So they're fond of ultrasound. So this is their specific skills. So first they will like, you know, as we do in part 2 and part 3. So the same skills are being used there. This is information gathering. Then there is a diagnosis, investigation. We send investigation, blood investigation, and then ultrasound or MRI or CT scan, what all you will offer, any information which you will provide to the patient about the diagnosis. So there comes your applied clinical knowledge. Yes, and it is here, like you see. Okay, I'll open my pointer. Yeah, so here you can see this PX, this is problem identify, then make the diagnosis by investigation, as we do in for the MRCOG part 3 and EBCOG part 2, and then give the information to the patient about the diagnosis. Here your communication skill with the patients come. Then what are the indication for the treatment? What treatment will you offer conservative treatment and surgical option. Yeah, so both of the treatment you have to explain to the patient. So this is your applied clinical knowledge. So all the domains they test in their both of the parts, part 1 as well, part 2 as well. It is slightly different from MRCOG part 2 exam in the way that in MRCOG part 2 you can blindly rely on guidelines and TOGs. Yeah, so the whole of the and strategy. So all the questions will come from there only. They don't put extra questions, or they don't expect you to clear part 3 in part 2. But in EBCOG there is quite a intermixing. Like if you need to know the clinical things as well. So so in this condition, you will be, in part 1 also you will be preparing on the as per the clinical scenarios, not as per the guidelines only. Then it will be very easy for you. And okay, so now there are in study material, there are GTGs, there is NICE, there are ASHRAE guidelines. ASHRAE guidelines are endometriosis, PCOS, RPL, and premature ovarian insufficiency. These are some of their hot favorite guidelines, and most of the paper like subfertility they make from these guidelines only, endometriosis and PCO. POI questions also comes, and RPL is very favorite. And then there are uterine anomaly paper is there, so they give so many questions from here and there, but they are clinically related to the patient, so you need not to mug up anything from any of these things, but you just need to know the difference. Then for cancers, they also, though there is a different gynae European Society for Oncology, but they follow this FIGO as well by heart. So if you know the FIGO guidelines, all the updated FIGOs for FIGO for the cancers, then you can easily solve all the onco cases, onco questions. Yes, and most of the questions are EMQs. They will give you 90 EMQs and 30 SBAs. So this is the ratio over there. So one should be very thorough with the EMQs, and in EMQs also they have a very different pattern. You have to give the most appropriate answers. So in most appropriate answers, you will be, even there were some questions in my exam that for 4 or 5 questions continuously all have the single answer. And I was very surprised that, either I am thinking wrong or they have framed the question wrong. But in that module, I almost cleared all the, they give marks according to module wise. So according to my marks, I think I was right. So that's why I can say that they have a different pattern, and they write it also that you have to write the most appropriate answer, and it can be one for so many. So here slight difference again from the part 2. And now they have released, some of the textbooks, EBCOG textbooks. These are the Tahir Mahmood is the editor in this. So these books have come up in market. So they are good books. We will be doing topics from these books as well. Yes, and there are 3 volumes in this: obstetric and maternal fetal gynae, and this is a this is overall obstetric and gynae textbook. So I think these are the 2 divisions. I have 2, this gynae and obs with me, but there was no information about the previous one, so I'll check it out. And then there are EMQ books. I'll recommend you that you all should be thorough with these EMQ books. Okay, so as Rashmi has also told in her session, so these books are the similar one, and they all has to be covered. So in the group also, we'll try that we start with one book, and we quickly finish with the EMQ books, so that you are oriented towards EMQs, because SBAs are comparatively easy than the EMQs. So there were SBAs and EMQs only, and here is the example that you have to give the single best answer. So like there was a question like 25-year-old woman, she is currently on liver enzyme inducer and is requesting the contraceptive advice. what is the most reliable form of contraception in this situation. So she is on liver enzyme inducers. So because the paper is very lengthy and there are all EMQs, so for SBS you can't put up so much of time. You have to quickly do it. There is only one problem in this exam is shortage of time. So if you manage your SBS, then you can easily cover up with the exam. So in this you have, once you have seen liver enzyme inducers, so here what and most reliable, always pick up the keywords. Here we have to see the most reliable and we have to see the enzyme inducer. So most reliable, this condom and diaphragm is out already. COC and progesterone is out because of liver enzyme inducer. We have only LNG-IUS as the answer, right? And similarly, there are the EMQs. So for EMQs also, there is a smart technique to see what this EMQ is giving. These all are the treatment options. Yes, there are no investigations and nothing else. So this is for the regarding the infertility treatment. So we will not be going into further thinking about the most appropriate next investigation. We'll directly jump onto the treatment. So like here is a question, like 34-year-old woman with 3-year primary infertility has been referred to the clinic. Her past medical history is not significant, like regular periods, HSG showing bilateral tubal block. Yeah, so what we do regularly is to offer her laparoscopic, diagnostic laparoscopy and hysteroscopy. But here next clue is her husband has severe oligo. So it has been already diagnosed. So we will not go for repeating the husband's semen or something like that. We know that she will need IVF ICSI. Yes. So because severe oligozoospermia is there, so treatment is ICSI, and she has tubal blockage as well. So we'll go here and we will go to the B. That ICSI is the answer. Yes. So just like that, we have to solve it. They are very simple questions, but we need to know the technique of doing it and practice. That is the essence. And okay, I'm going reverse. Yeah. So 29-year-old woman with 2 years primary infertility has been referred to the infertility clinic. She has regular periods while her past medical history is not significant. Her husband is 30-year-old and the semen analysis shows persistently low count, almost azoospermia. Okay, so there's no sperms. There are no sperms, so he has low serum levels of FSH and LH in the area of hypogonadotropic hypogonadism. So again, now we have to see the treatment. And they have themselves given the hypogonadotropic hypogonadism as the diagnosis. So what do we give? We treat with the gonadotropins. So here the treatment will be FSH and HCG. Yes, and you can see that they have given reference from NICE only. This is their paper. Yeah, for the sample questions which they send us. So this is they have taken their questions from the NICE. Directly they pick from the guidelines. They like NICE the most, and then ESHRE, and ESHRE for few of their guidelines, because there is a long list of guidelines on the ESHRE board, but we don't have to do all of them, just selected. Yes, and then there is a last like 3 years of primary infertility, 32 years old woman, regular cycle, patent tube, husband is 35 years, past medical is not significant, moderate semen abnormality that are characterized as idiopathic. In the semen, in his semen, a number of leukocytes are identified. So we know the NICE guideline, the leukocytes, even if they are identified, we don't have to do anything, no antibiotics. Yes, so what we will be offering her, because of the moderate semen abnormality, we'll be offering her IVF. So there again the treatment will be IVF. And so this is all about APCOG. If anybody had, now the question again, the key question is why to go for it. So we have seen the benefits. So it's just the academic excellence. It is it's a global achievement kind of a thing. Like you have your presence in Europe as well, European Board of Ops and Gynae. And yes, they say that it helps you in medical legal updates as well, because they keep on updating you, and the more you know, the less you are trapped in the medical legal things. So because there are always references which works in the medical legal department. So European board keep you updated with the medical legal things as well. And for your self-confidence, that's a big, huge thing. So, and it was the only thing, academic excellence. That is why I went for this degree. So that's all about it. If anybody has any question, they can ask.
Yes, okay, Jeet. So thank you so much for the wonderful orientation and giving them the real picture about what EBCOG is and what are their choices to opt for this exam as well. So that was a lovely orientation session. Thank you so much. And any other doubts, anything regarding the course and the curriculum, how we're going to practice? If you have doubts, then please get back to us. We have the free Telegram groups, and Dr. Jatinder Kaur is available there. She'll be taking up all your questions too and dealing with this. So thank you so much, all of you, for joining in, and have a wonderful day. Thank you all.
Thank you, Rashmi. Okay, bye.
Thank you. Bye bye. Take care.
Thank you.